Welcome back to the deep dive. We've got a massive stack of sources from you, the listener, today.
We really do.
And it's on a topic that is, it's revolutionary, it's frustrating, it's just incredibly complex.
Gene therapy.
Gene therapy, yeah. This field, it promises to literally rewrite our own genome to treat or even cure disease.
But the path to get here, as our sources show, has been anything but a straight line. It's been more like a roller coaster.
An exhilarating and, at times, a pretty terrifying roller coaster.
This is exactly right. And our focus for this deep dive is really on technical mastery. We're going to tear down the fundamental biological barriers, the things that have to be overcome for this to actually work.
And we'll be looking at the delivery trucks, the vectors that carry the genes.
And then we'll apply all that knowledge to two very different clinical case studies. First, cystic fibrosis.
The classic, what seemed like a simple genetic target.
And then head and neck cancer, which is a far more complex oncological challenge.
Yeah. So our mission today is to really get past the headlines and dig into the mechanics. At its core, gene therapy is the delivery of exogenous genetic material.
Meaning genetic material that comes from outside the patient.
Right, and it's delivered into a host cell for some kind of therapeutic purpose.
The whole strategy is designed to be, restorative or regenerative or protective. You're trying to replace or suppress or even enhance a gene's expression for people with these debilitating genetic defects.
It really is. It feels like the ultimate expression of the allure of modern science.
And that allure, it led to this incredible rush of enthusiasm back in the early 2000s. The first really notable success was in treating severe combined immune deficiency, SCID.
That's the bubble boy disease, right?
A terrible nickname, but yes. For children with SCID, getting a replacement for their immune system was, it was literally life-saving. And those early successes made everyone think broad cures were just around the corner.
But the field learned a very painful lesson very quickly.
Oh, yes.
Yeah.
That initial success was followed by some truly devastating setbacks. It was a massive reality check for the whole community.
We saw that tragic event in 1999, the death of a subject in an adenovirus trial.
At the University of Pennsylvania, yes. And then, just a few years later, in 2002, we saw major complications in those very same SCID trials that had seemed so successful. A small number of those young patients who had gotten the retroviral therapy, they developed a severe cancer-like condition.
Okay, let's just clarify that risk for you, the listener. When we say a tragic event leading to a lymphoproliferative disease, we're not talking about a minor side effect here.
Not at all.
What biologically went so wrong?
We're talking about a terrifying side effect of the vector itself, the delivery vehicle, integrating into the host's own DNA.
Okay.
So lymphoproliferative disease means an uncontrolled overgrowth of white blood cells. It's essentially a form of therapy-induced leukemia. The vector, which was supposed to just deliver a missing gene, it accidentally inserted itself right next to a proto-oncogene.
And a proto-oncogene is a gene that controls normal cell growth.
Right, and by inserting there, it basically flipped a switch it shouldn't have, turning that growth gene on permanently, which led to uncontrolled cancer.
That one event must have just slammed the brakes on the entire field.
It did. The entire scientific world had to stop and fundamentally reassess the biosafety risks of just randomly inserting new genetic material into the human genome.
Yeah.
It was a massive crisis of confidence.
And yet, out of that period of, intense scrutiny and much better engineering, the field has actually met some remarkable milestones.
Absolutely. We've seen sustained clinical trial success in treating conditions like Leber's congenital amaurosis, which is a form of blindness, and X-linked adrenoleukodystrophy, a really severe neurological disorder.
And beta thalassemia, too.
And beta thalassemia. These achievements show that we are getting much, much better at managing those biological hurdles.
If you look at the long-term data from those original SCID patients, it just illustrates this complex outcome so perfectly.
It really does.
The 10-year data shows that 18 out of the 20 patients are still alive, and 17 of them had their immunodeficiency corrected. That is a profound clinical success.
It is. But the shadow that hangs over it is that 4 of those corrected patients did develop leukemia. It's this constant reminder that while we have these powerful tools, we still don't have perfect control over them.
And this whole journey from tragedy to a more cautious triumph, it accelerated the shift from just research to actual commerce.
It did. In 2012, the European Commission approved alipogene tiparvovec, which is sold as Glybera.
And that used an adeno-associated virus, or AAV, vector?
Carrying the human lipoprotein lipase gene. This was a watershed moment. It was the first commercially available gene therapy drug approved in the Western world for a rare condition called familial lipoprotein lipase deficiency disease.
If we look back at the scope of the field around that time, say 2012, our sources say there were about 1,800 human clinical trials happening globally.
And the variety is really striking. It shows you where the biggest needs and the biggest opportunities were.
So what was the breakdown?
The clear leader, by far, was cancer. That had the largest number of trials.
Okay.
Second were the monogenetic diseases, so things like cystic fibrosis and hemophilia B, the so-called single type O diseases.
Right.
After that, cardiovascular disease was third, and then fourth was infectious disease, which back then was almost entirely trials focused on HIV, the human immunodeficiency virus.
But no matter what the disease is, the core mission is the same, right? You're delivering this genetic material to the target cells using these vectors.
Pretty specialized vehicles, yeah. Usually they're replication-deficient viruses, but sometimes non-viral options like liposomes. They're literally the delivery systems designed to sneak past the host's formidable natural defenses.
So all of those early triumphs and those terrible tragedies, it really all comes down to one variable.
The delivery truck itself.
Exactly. So now we have to look under the hood at these vectors and really understand why some of them crashed and burned and why others soared. Okay, let's unpack this. Let's get into the mechanics of vector delivery.
Before we can even start analyzing the tools, we have to define the ultimate obstacle course that the therapeutic gene has to navigate.
Okay.
For a gene therapy to actually work, for the gene to be expressed in the target cell, there are 4 critical barriers that have to be overcome. If the vector fails at any one of these steps, the entire therapy just collapses.
What's the absolute first step, the one that gives the therapy any chance at all?
Number 1 is targeting. It's all about specificity.
So making sure the package gets to the right address.
Exactly. If we're treating a genetic liver disease, we absolutely must ensure that the vector only infects or is taken up by liver cells. If it just expresses the gene everywhere in the body, you risk systemic toxicity, or you're just wasting the therapy where it isn't needed.
And that specificity is hard to engineer.
Very hard. Okay, so assuming the vector hits the correct tissue, what's the second hurdle it faces at the cellular level?
What's next?
Barrier number 2 is binding and internalization. This is also called transfection.
So it has to actually stick to the cell and get inside.
Right. The vector has to have the right surface chemistry or the right receptors to first bind to the cell membrane and then, crucially, be successfully pulled inside the cell. If it just bounces off, the mission's over before it starts.
And I'm guessing the third barrier is where it runs into some serious trouble with the cell's own security systems.
That's exactly right. Barrier 3 is cellular trafficking to the nucleus. We call this transduction.
Okay.
See, most cells internalize outside material by wrapping it in this tiny bubble called an endosome.
And the endosome is basically a cellular stomach.
It's a perfect way to think about it. It's designed to break down and digest whatever gets trapped inside. So if your genetic material doesn't escape that bubble, and quickly a process called endosomal escape, it just gets digested before it ever reaches the cell's control room, the nucleus.
So the therapeutic gene is like this classified message that has to escape its protective but also very dangerous packaging before it gets shredded.
That is a perfect analogy. And that brings us to the final barrier, number 4, nuclear expression.
So it's finally made it to the nucleus. Now what?
Now, the stability of that genetic material, does it integrate into the chromosome or does it remain separate?
Mm-hmm.
And the quantity of gene expression have to be determined. Is it actually producing enough of the replacement protein to be therapeutic? And is it going to stick around long enough to matter?
And every single vector type we're about to discuss manages these 4 steps very differently.
Dramatically differently, yes.
This brings us to the comparative analysis. I mean, the sources basically lay out this fundamental war of compromises in gene therapy design.
That's perfect framing.
It seems like if you want guaranteed long-term expression, you have to sacrifice some safety and face those integration risks.
Correct.
But if you prioritize safety and maybe a large cargo capacity, you risk the therapy just washing out and disappearing too quickly.
That is the essential dilemma. The choice of vector dictates the entire clinical strategy. So we need to look at 5 critical metrics for these vectors. What their genome is made of, their tropism, which is just which cells they infect,
right,
how they interact with the host genome, how long their expression lasts, and their packaging capacity.
Okay, let's start with the one that was involved in those early setbacks, adenovirus.
Right, Adenovirus uses a large double-stranded DNA genome. Its biggest asset is its versatility, its tropism. It can efficiently infect both dividing and non-dividing cells, which is a huge plus.
But its core limitation is.
It's non-integrating. It stays separate from the host genome. And that means the expression is transient. It just disappears as the cells divide. It has a decent packaging capacity, about 7.5 kilobases.
Okay. Next up, the vector that actually delivered that first commercial success, adeno-associated virus, or AAV.
AAV is extremely popular today for good reason. It uses a single-stranded DNA genome, and like adenovirus, it infects both dividing and non-dividing cells, and it's also generally non-integrating.
But the key difference here is the expression duration.
Exactly. It offers potential long-lasting expression, which is a huge advantage we'll get into. The major trade-off with AAV, though, is its really restrictive packaging capacity. Only about 4.5 kilobases.
So if your therapeutic gene is big, AAV is just off the table.
Completely off the table.
Then we get to the really high-risk, high-reward systems, retrovirus and lentivirus.
These use a single-stranded RNA genome, and they are the only systems that are designed for integrating into the host genome.
And that integration is the whole mechanism that delivers that long-lasting expression.
It is. The older retrovirus systems could only infect dividing cells, which severely limited their use. But the newer lentivirus, which is based on engineered versions of HIV, can infect both dividing and non-dividing cells. They have a pretty good packaging capacity, too, about 8 kilobases.
And finally, the completely non-viral option, naked DNA vectors.
Right. These are basically just simple plasmids. They offer simplicity and maximum flexibility. They have an unlimited packaging capacity and can infect any cell type.
And they're non-integrating and very safe.
The safest in terms of cancer risk.
Mm-hmm.
But their major drawback is that expression is almost always transient because the efficiency is just so low that it don't persist.
So looking at all of them, a chart really just reveals that essential dilemma: safety or persistence. If you want a real lasting cure, you need persistence.
Which generally means integration.
Which carries the risk of cancer. It's a terrifying biological tightrope walk.
It really is.
Okay, let's focus now on adenovirus, the early workhorse of the field.
It's a non-encapsulated human pathogenic DNA virus. Its main advantage, and the reason it was so popular early on, is just its sheer efficiency at getting past barriers 2 and 3, internalization and trafficking.
It's just really good at getting inside the cell.
Incredibly good. It binds very efficiently to a receptor called the Coxsackie adenovirus receptor, and it's amazing at endosome escape and getting to the nucleus.
So it's a fantastic delivery system, but it kind of burns the bridge behind it.
Precisely. Its major drawback is its overwhelming immunogenicity.
The immune system sees it coming from a mile away.
Oh, yeah. The host immune system recognizes this virus as one of the causes of the common cold, as a massive threat, and it mounts a fierce response. Both the cell-mediated and humoral immune systems get activated. If you give a dose greater than 10 to the 10 particles, which is a common therapeutic dose, you trigger this huge inflammatory response.
And that immune reaction is what led directly to that tragedy in the late 90s. The patient didn't die because of the therapeutic gene. They died because of the massive system-wide inflammation from the viral vector itself.
That is the crucial distinction.
Yeah.
The toxicity was vector-induced. And on top of that, this intense immune response means you can't redose. The host develops antibodies, and the immune system just clears out any cells that have the vector.
So if the problem is the immune system recognizing the virus, what are the strategies to try and make it invisible?
Well, the most sophisticated strategy is creating what are called gutted vectors. Researchers essentially strip the adenovirus of almost all of its native viral genes. They leave only the bare minimum needed for packaging and the therapeutic gene itself. These gutted vectors are far less immunogenic, and they can express the gene for longer in vivo.
That deals with the vector, but what about the host's response?
We also use localized immune modulation. So you're temporarily dialing down parts of the host immune response right at the time of delivery, just to blunt that initial inflammatory reaction.
But the transient nature is still the fundamental limitation, right?
It is. The integration risk is 0, which is great. But for a chronic disease, transient expression is a huge problem.
Okay, let's pivot to AAV, the current superstar. It's a single-stranded, encapsulated parvovirus. What makes it so much safer than adenovirus?
It really comes down to safety and persistence. First, AAV in its wild form isn't associated with any known human disease. And when we engineer it into a vector, we remove all the viral proteins.
So much quieter immunologically.
Much quieter. It results in very little immunogenicity. You avoid that acute, life-threatening response you can see with high-dose adenovirus.
And it still hits both dividing and non-dividing cells. But that potential long-lasting expression for a non-integrating vector? That's the real puzzle piece. How does it manage that?
It has a clever trick. It manages persistence differently depending on the cell type. In quiescent, non-dividing cells, which make up most of the organs in an adult AAV, can actually integrate into the host chromosome.
Oh, I thought it was non-integrating.
It generally is, but in rapidly dividing cells, it does something else. The viral DNA remains in the nucleus as an extrachromosomal episome.
An episode.
Yeah, you can imagine it as a separate, stable little circle of DNA just floating inside the nucleus, constantly being transcribed. This allows gene expression to continue for much longer than a standard plasmid or adenovirus would.
And that stability is what led to the first commercial success, Glybera.
That's right. The alipogene tiparvovec AAV vector proved that AAV could deliver sustained, clinically meaningful results for that lipoprotein lipase deficiency.
But the big shadow hanging over AAV is its size limit.
Absolutely. The biggest limitation is that small packaging capacity, maxing out around 4.5 kilobases. A lot of critical therapeutic genes are just too big. For those therapies, AAV is simply not an option.
And it used to struggle with efficiency too, right?
Correct. The expression was often inefficient, sometimes taking weeks to build up to a therapeutic level. But the newer generations of AAV vectors are showing massive improvements, much shorter turnover times, and dramatically enhanced potency. That's why AAV is the backbone of so many successful trials today, especially for the eye, liver, and muscle.
Okay, so now we have to talk about the systems that carry the highest reward and the highest risk.
Retrovirus and lentivirus, the single-stranded RNA viruses.
And the primary advantage here is that mechanism of integration. The RNA gets reverse transcribed into DNA, goes to the nucleus, and inserts itself directly into the host chromosome.
Which results in that guaranteed, persistent, long-lasting gene expression. For a chronic, lifelong disease, this is the holy grail.
Which is why these vectors are always made replication incompetent for safety.
Absolutely. They can insert the gene, but they can't produce new infectious particles.
The sources make a really stark distinction between the older and newer systems here.
Yeah, the older systems, which were based on murine oncogenic retroviruses, they had this debilitating limitation.
Yeah.
They could only infect dividing cells.
Which makes them useless for treating, say, the brain or adult muscle.
Exactly. The huge leap forward came with the lentivirus genus, which was engineered from viruses like HIV.
Okay, hold on. So we're using a version of HIV to treat people. I mean, that sounds like a terrifying Faustian bargain just to get long-term gene expression.
It is a very high-risk, high-reward strategy.
Yeah.
And I should be clear, the engineering involves removing virtually all the virulence factors. It's a highly attenuated delivery vehicle.
Yeah.
But the risk is inherent to the mechanism.
Insertion mutagenesis.
Yes. Since the vector insertion into the chromosome is uncontrolled, if it happens to land near or disrupt a proto-oncogene, it can trigger therapy-induced cancer, just like we saw in those SCID patients.
So the very thing that makes them persistent, the integration, is also the exact reason they can be so dangerous. It's the ultimate trade-off.
It's precisely the trade-off. The field has to accept that for now, achieving that sustained expression for some conditions requires integration, and integration carries a non-zero, albeit statistically small, chance of malignancy.
And what about the opposite problem? Not cancer, but the gene just getting silenced.
That's the secondary issue, chromosomal silencing. Even if the gene inserts perfectly, the surrounding DNA environment can turn hostile. Things like methylation can lead to a significant downregulation of the gene you just delivered, effectively silencing your therapy.
Are there solutions being explored to control this? To make it safer?
Yes, the focus is intense. Researchers are developing methods for controllable, site-specific insertion rather than random. They're also developing things called chromosomal buffers.
Buffers.
Yeah, sequences you insert alongside your gene that shields it from the silencing signals of the host genome. And they're even designing safety nets, like methods to controllably cut the provirus back out if it inserts in a dangerous spot.
Okay, finally, let's turn to the non-viral vectors. Naked DNA plasmids.
These are so appealing because they just circumvent all the biological complexity and risks of viruses.
They seem like the most logical choice, right? Simple, safe, easy to make.
Their advantages are clear. Simplicity, easy to produce at large scale, minimal immune response, and they can't cause insertion mutagenesis. And their unlimited packaging capacity is a huge bonus.
But they're not dominating the clinic, so why the disconnect?
The single biggest obstacle is just abysmal efficiency.
It just doesn't get in.
Most of it is simply not internalized by the cells. The targeting is poor. And the tiny fraction that does get in faces that massive hurdle we talked about, high endosomal degradation. It gets chewed up before it reaches the nucleus. So low binding, high digestion, poor nuclear delivery.
And like adenovirus, the expression is transient. It gets lost when cells divide. So how do researchers even try to force this DNA into the cells?
Well, one method is using liposomes. These are cationic lipid spheres that bind to the DNA and form complexes that get incorporated by the cell. Another method is ballistic gene delivery.
Wait, did you just say ballistic gene delivery? That sounds like a gene gun.
It is literally a gene gun. It uses a pressurized system, usually helium, to shoot tiny microcarriers coated with DNA into exposed surfaces like the skin or the eye.
Oh, wow.
It's been effective in the lab, in like mouse lungs, but designing the equipment to do that safely and precisely deep inside a human organ is a massive engineering challenge.
So the main driver for research here must just be the safety and scalability.
Absolutely. The focus now is on combining these methods with other techniques, like using electrical pulses electroporation to open the cell membrane and trying to improve the stability of the plasmid itself.
Here's where it gets really interesting. We've broken down the molecular tools. Now let's see these vectors put to the test in the real-world clinic. Starting with a disease that seemed just tailor-made for gene therapy, cystic fibrosis.
Cystic fibrosis is often called the seemingly ideal candidate, and it's easy to see why. It's the most common lethal genetic disease among certain populations, with a median survival under 40 years, almost always due to pulmonary failure. And critically, it's caused by a mutation in a single gene.
The hypothesis is simple. Fix the one typo, fix the entire disease.
That was the dream. The gene is the cystic fibrosis transmembrane conductance regulator, or CFTR gene. It was discovered in 1989 on chromosome 7.
And what does that gene do?
It codes for the CFTR protein, which acts as a CAMP-dependent chloride channel on the surface of epithelial cells.
So it's a little gate for chloride ions. What happens when that gate is broken?
The abnormal CFTR protein messes up the whole balance of salt and water transport. Chloride ions get stuck inside the cell, water fails to follow, and you end up with this characteristic thick, sticky mucus.
And that one defect causes all the downstream problems.
All of them. The increased salt and sweat, the obstructive lung and sinus disease, the pancreatic insufficiency, male infertility. It's a multi-system disease from a single gene defect.
And the vast majority of cases boil down to one tiny specific typo.
Exactly. The key mutation is the deletion of a single phenylalanine residue at position 508, or E508. This one mutation accounts for about 70% of all cases. So targeting this one specific protein function is the goal.
So the ultimate goal is to treat the lungs, but the early trials all use the nose and sinuses as a model. Why start in the nose when it's the lungs that kill the patient?
Because the lungs present massive difficulties, especially in adult CF patients who already have severe compromise, mucus plugging, chronic infection. Any adverse reaction to the vector, like that inflammation we saw in the 94 trial, is far, far riskier in the lungs.
So the nose is a low-risk, easily accessible testing ground that has the same basic cellular defect.
Precisely. The nasal and sinus mucosa is easy to get to. And importantly, we have a reliable, non-invasive way to measure success there. The nasal potential difference.
Explain the nasal potential difference for us.
The nasal lining in CF patients has a distinct bioelectric phenotype. Because that chloride channel is broken, the electrical potential across the cell layer is more negative than in healthy people.
So if the therapy works,
if you successfully deliver a functional CFTR gene, you should see a measurable, reproducible correction of that electrical potential back towards normal. It gave researchers an essential objective endpoint for the early trials.
the progress started in animal models, but the early mouse models weren't quite right, were they?
The early successes in cultured cells confirmed it was biologically feasible, and the transgenic CF mice were useful, but they didn't fully replicate the severe lung and sinus disease we see in humans. The real breakthrough came with the transgenic CF porcine models.
The pigs, why were the CF pigs so critical?
Because they faithfully recapitulate the human phenotype. When researchers knocked out both copies of the CFTR gene in these pigs, they developed the same ion transport defects and multisystem disease seen in humans, including the severe sinus disease. It gave us a much more predictive and accurate model for testing these complex delivery strategies.
Okay, so with that model established, let's see how the vectors actually did in human trials, starting with the one that was most efficient at delivery, adenovirus.
Most of the early U.S. trials favored adenovirus because of its natural tropism for respiratory cells. And Zabner and his colleagues in 1993, they did report success.
But
but it was limited to only transient correction of that nasal bioelectric potential. It worked, but it faded fast.
And that high efficiency came with that massive toxicity risk, as we saw in the 1994 trial.
That trial used a pretty high dose delivered to the lungs, and it resulted in that acute vector-induced inflammation. This wasn't an integration risk, it was the sheer force of the immune system reacting to the high viral load.
And that event immediately led to dose reductions across the board.
Widespread dose reduction. And even with lower doses, the problem of repeat administration was impossible to solve.
You can't use it more than once.
Basically, no. Zabner's later trials showed this unavoidable immunologic response to repeat applications. It just neutralized the vector. And on top of all that, there was a structural barrier.
It was that.
The receptors for adenovirus are often on the basolateral membrane. That's the side facing away from the airway. So the vector has to somehow get through the protective layer of cells just to bind.
So researchers had to temporarily loosen that protective layer.
Yes. One strategy used calcium chelators to briefly disrupt the tight junctions between the cells, just to let the vector sneak past and access those receptors. It shows you the incredible lengths they had to go to just to get the delivery truck to the front door.
Okay, so let's move to AAV. It solves the toxicity problem, it has lower immunogenicity, and some types of AAV can even enter from the right side, the apical surface.
AAV seemed perfectly positioned. Wagner and his colleagues used the maxillary sinus as a model. It's a nice, contained environment. And they detected the gene transfer as late as 41 days. Great persistence.
What?
But this is where the low efficiency of AAV became the ultimate stumbling block for CF.
So even though the vector stayed in the cells for over a month, it just wasn't making enough of the protein to matter.
Precisely. The overall level of CFTR reconstitution was just too low to provide any measurable functional correction of the bioelectric potential. The safety was excellent, the persistence was good, but the therapeutic dose just wasn't reached.
Which pushes us back toward integration, specifically lentivirus. It offers persistence, and it can transduce non-dividing cells, which is perfect for the airway.
The use of lentiviral vectors, mostly based on feline immunodeficiency virus, or FIV, is highly attractive for CF for exactly those reasons. But the shadow of insertion mutagenesis means that progress has been, and continues to be, very cautious.
And finally, the completely safe but transient non-viral vectors using liposomes.
Kaplan and colleagues in 1995 actually achieved a notable 20% correction of the nasal potential difference using cationic liposomes delivered with a simple nasal pump spray.
So it showed delivery was possible?
It was, but the effect peaked at 3 days and was completely gone by day 7. For a chronic, lifelong disease, a 7-day window of benefit is, well, it's clinically irrelevant.
And later trials even started to question the absolute safety of the nasal model itself.
That's right. A double-blind trial by Alton and his group that used pulmonary administration, it showed some improvement, but it also noted some toxicity with the lung delivery that wasn't apparent in the nasal model.
So the nose is a good starting point, but not a perfect predictor.
Exactly. It might not fully predict the inflammatory risks of treating the primary site of the disease.
So what does all this mean for CF? I mean, the progress in understanding the molecular basis of the disease has been enormous, and vector science is light years ahead of where it was.
But the clinical challenge remains massive. It's all about translating that success we see in the lab into a clinically relevant, measurable, and sustained functional endpoint in a patient.
The difficulty of achieving widespread, sustained delivery across the entire vast, damaged surface of the CF lung, that remains the primary biological barrier.
It does.
Okay, now we shift gears completely. We're moving from the monogenetic replacement therapy of CF to a disease with a highly disparate and complex genetic basis, head and neck cancer.
Head and neck cancer, or HNC, is such a critical area for innovation. Despite all the advances in surgery, radiation, and chemotherapy over the last 40 years, the survival rates for advanced stage cancer have just remained stubbornly stagnant.
So the need for alternative, biologically targeted strategies is urgent.
It is.
And this isn't about replacing a missing functional protein, is it? This is about actively disrupting uncontrolled growth that's driven by multiple mutations.
That's the key distinction. We're using gene therapy here to provide alternative strategies that target the biological basis of oncogenesis, not just the tumor bulk. And these strategies generally fall into 4 key categories.
Okay, what are the 4 main avenues?
1 is chemosensitization, which also includes restorative gene therapy. 2 is cytokine gene transfer, which is focused on immune modulation. 3, inactivation of proto-oncogene production. And 4, selective oncolytic viruses.
Chemosensitization sounds incredibly clever. You're basically weaponizing the cancer cells against themselves to make standard treatments more effective.
That's the core principle. We deliver a gene selectively to the cancer cells, and then we use a standard secondary therapy radiation or chemo to activate a killing mechanism.
The classic example of this is the use of so-called suicide genes like herpes simplex thymidine kinase.
Right. So the strategy is you deliver the gene for the HSV-TK enzyme. The enzyme itself is harmless, but once it's expressed in the cancer cell, it acts like a molecular switch.
A switch for what?
It converts a relatively inert prodrug called ganciclovir into a highly toxic nucleoside analog, which rapidly kills the cancer cell.
And this mechanism is magnified by the crucial bystander effect.
This is what makes the whole strategy efficient enough to be clinically viable. The infected cell actually spreads the toxic product to its surrounding uninfected cancer cell neighbors through cell-to-cell contact.
So you don't even have to infect every single cell.
Not even close. Lab experiments have shown that thanks to this bystander effect, you might only need to successfully infect about half the tumor cells to get a destructive outcome across the entire mass.
And within this same category, we also find restorative gene therapy, which is about returning the cell's ability to die gracefully.
Yes, specifically restoring apoptosis or programmed cell death. The idea is to deliver a gene like the p53 tumor suppressor gene, which then sensitizes the cancer cells to die after you hit them with standard therapy.
And p53 is a prime target because it's so commonly mutated in these cancers.
p53 and p16 are the two most common mutations in head and neck squamous cell cancer. They're the top restorative targets.
But how did the p53 trials actually do in the clinic?
The results were modest, again, hampered by efficiency and targeting problems. There was a phase I trial that used an adenoviral vector encoding p53, injected directly into the lesions of 33 patients with recurrent cancer.
And what did that trial show?
The responses were really limited and inconsistent. And here's the critical takeaway. The clinical responses they saw did not correlate with the patient's existing p53 status.
So it didn't matter if the patient's tumor already had a p53 mutation or not.
Exactly. The result of the therapy seemed almost random, which suggests that gene replacement just wasn't reliably achieving its goal.
But despite those inconsistent results, this specific therapy did achieve a pretty big regulatory milestone in Asia.
It did. A drug called Gendathin, which is a modified adenovirus with p53, was approved in China for HNC back in 2004. It was the first clinical gene therapy drug approved anywhere in the world.
But the Western version was refused FDA approval.
Right, Advexin was refused FDA approval here in 2008. It really just illustrates the differing global benchmarks for efficacy, especially for brand new technologies like this.
Okay, the second major strategy is immune modulation, using cytokine gene transfer.
This is all about correcting the tumor's ability to evade the host immune system. HNC patients typically have a severely compromised local immune response.
Why are these tumors so often invisible to the body's natural defenses?
The tumors actively suppress the immune system. They create this state of immunological ignorance. They do it by, for example, downregulating their major histocompatibility complexes.
The flags that T cells use to identify threats.
Right. And they lose other necessary co-stimulatory pathways. And on top of that, the natural cytokine pathways that would stimulate T cells, things involving interleukin-2 or IL-2 and interferon gamma, are often depressed. The T cells just don't get the go signal.
So gene therapy offers a way to inject that go signal directly into the tumor's neighborhood.
Exactly. You overexpress those downregulated cytokine pathways locally to reactivate the dysfunctional immune response.
Yeah.
And this is hugely valuable because if you try to give a parasyl cytokine like high-dose IL-2 systemically, it causes severe side effects like capillary leak syndrome.
So gene therapy lets you get a high local dose without the systemic toxicity.
Precisely. Phase I trials using non-viral plasmids expressing IL-2 have confirmed that it's safe, and Phase II trials are ongoing, now looking at more complex combinations of these agents.
Okay, this brings us to the final strategy, which is arguably the most elegant and the most promising.
Selective oncolytic viruses. This moves beyond simple delivery and turns the viral vector into a smart, self-propagating weapon.
So you're taking the natural cycle of a virus where it replicates and destroys the cell, and you're engineering it to do that only in cancer cells.
That's the core concept. We're harnessing the natural cell-destroying power of a wild-type adenovirus. But we've engineered a version that creates a continuous, self-propagating treatment.
Right.
The virus just keeps making copies of itself and destroying tumor cells until, theoretically, the cancer is gone.
And how is this specific virus, ONYX015, engineered to make sure it only attacks cancer?
This is a remarkable piece of molecular engineering, and it's all based on that p53 pathway we talked about.
Okay.
The ONYX015 adenovirus is missing a crucial gene, E1b. Now, in a healthy, normal cell, the E1b gene's job is to inhibit the cell's p53 protein.
So if ONYX015, which is missing E1b, infects a normal cell.
The functional p53 protein in that normal cell recognizes the viral attack, it hits the brakes, and it stops the cell cycle. And that prevents the virus from being able to replicate.
But the vast majority of these head and neck cancer tumors have non-functional or missing p53.
Precisely. About 60% of them lack functional p53. So in those cancer cells, the p53-mediated safety brake is already gone. The missing E1b gene in the virus doesn't matter. And ONYX015 can replicate freely, destroying the cancer cell and releasing more viral particles to infect its neighbors.
So the virus is perfectly designed to selectively replicate and destroy only those tumor cells that have that specific p53 defect. It uses the tumor's own vulnerability against it.
It is the definition of a targeted biological therapy. And the phase I trials confirmed it was safe. The real excitement came when they combined it with chemotherapy.
What did those phase 2 combination studies show?
They showed dramatic synergy. Adding intratumoral injections of ONYX015 to standard chemotherapy 5-fluorouracil, or 5-FU, and cisplatin increased the objective response rate from a standard 33% with chemo alone to a remarkable 65%.
Wow.
It proved that the selective destruction from the oncolytic virus was making the remaining cancer cells far more susceptible to the standard chemotherapy.
And the future potential here extends beyond just local lesions, right? It could be a systemic treatment.
Yes. Phase I trials have confirmed that intravenous delivery of ONYX015 is safe, which opens the door for treating distant metastasis. Now, the challenge of getting the virus through the body without the immune system clearing it is immense, but the possibility of turning a deadly cancer into a manageable disease through this kind of targeted viral destruction is incredibly promising. So when you pull back and look at the whole field, you see this constant tension, right?
Absolutely. It's this incredible therapeutic promise. Personalized curative medicine at its most fundamental level.
Versus the reality of these inherent biological complexities and risks. The toxicity, the immunogenicity, the transient expression, or the terrifying risk of uncontrolled integration.
And we can't overstate the importance of that history here. The death in the 1999 adenoviral trial, the leukemia cases after the SCID trials, they were tragic, but they served as this brutal biological proving ground.
They did. They forced us to move past simplistic delivery ideas and embrace a much more sophisticated molecular understanding of how the host and the vector interact. And that's what's made the current era of gene therapy possible.
Gene therapy is no longer just experimental, it's clinical reality. We have successful, sustained results and commercial approval with drugs like Glybera.
The foundational science from learning how to engineer endosomal escape to designing a tumor-specific killer like ONYX015 has never been stronger.
The ultimate challenge now is translation and scaling. We have to take all this molecular expertise and translate it into effective clinical strategies that are safe and effective for entire organs or for widespread metastatic disease.
For oncologists, otolaryngologists, and geneticists, mastering the characteristics of these vectors is absolutely essential. The delivery vehicle is quite literally half the therapeutic battle.
We've proven we can repair a single genetic typo. We've proven we can selectively destroy cancer based on its own genetic defects. But if you look beyond the current vector technology, which is all based on using these biological or lipid carriers, the true goal is creating a perfect delivery system.
Exactly.
So, given the rapid progress we've tracked today, think about this. What specific genetic editing or targeted delivery mechanism beyond our current vector technology will redefine the clinical utility of gene therapy in the next decade? The ultimate barrier might not be finding the right gene to fix, but manufacturing an immune-invisible, self-sustaining vector for mass therapy that is both infinitely scalable and zero risk.
That is the final, greatest mountain left to climb.